Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
Hi, we're so excited for this episode. So it's Acne Awareness Month. And of course, acne is one of the most common things that we treat in the office, but also probably outside the office that people ask us about. So I'm excited about that, the topic itself, but most importantly, I'm excited by who I'm joined with because we have such a wide range of expertise in this world. So first, of course, we have Dement. She is a senior director of North American marketing at Cutera, which is a leading laser company that has lots of laser technology, but most importantly, one of the 1726 nanometer, very novel technologies for the treatment of acne. And I think it's just so great to get your insights as well, because there's the way that we think as dermatologists, and then there's all the market research you've done, and then just kind of understanding what our patients are thinking through surveys and market research and these group things versus like our 10-minute visits where we might not get to these interactions. So I'm so excited to get into that. And then, of course, we have SF Derm board member, dermatologist extraordinaire, Dr. Ekama Carlson, who everyone knows really well, needs no introduction, but she is a board-certified dermatologist and a Mohs surgeon, owner, medical director of the California Center for Dermatologic Surgery in San Francisco. And you are just incredible in how I feel like you go for treatment early and effectively. I feel like whenever I've heard your talks, you don't mess around. You're like, if you're coming to me and you're bothered by this, we're going to treat it. We're going to treat it fully. Like, you have all the modalities in your office. So I'm so excited to kind of cover all of this. So maybe actually I'll start with you, Erica, because I feel like we don't necessarily go out there and get this kind of experience that what the wider population is getting. We get a subset of people who are coming into the dermatology office. And even then we have a very short amount of time. Like, I know you've done like surveys and all that. I'd love to kind of hear your experience of what our acne patients are saying and kind of what they're looking for.
Absolutely. And thank you so much for having me on. This is an absolute honor. So last year for Acne Awareness Month, we wanted to get in touch more of what the modern acne patient was going through, not only from an emotional and psychological experience, but also what the next steps were in their acne journey and what their palette was for laser and light-based procedures. So what we found, which was super insightful, is that 80% of patients, or over 80% of patients, were actually interested in light-based procedures for their acne. So we see this shift in patients being more curious about different treatments that they could use. I think the other thing, and of course, we all know how emotional acne is for the patient, but I think a lot of people don't understand how that affects day-to-day life. And that's really what we wanted to focus on, is what was the daily impact of acne on your modern patient. And what we found is that you see a disconnection from society, from people not wanting to post selfies, pictures with their families, important moments. They were missing out not just on in-person events. A few years even before, we had ran a survey, and it was more for in-person events, graduations, weddings. Now we have this data showing that people don't even want to participate digitally. And so you find that there's even more of an isolating factor there. And so I think the light at the end of the tunnel is that we have so much online education now. People are getting curious and they have options, and they have options even beyond, what we've traditionally have had. And it can go from treating acne to getting to your dream skin, essentially. And that's, where our dermatology community comes into play, because there's so many wonderful things out there. And I'm so glad that patients are starting to get curious about it.
Yeah, thank you for sharing that. I think it's incredible. Like, we kind of know that as dermatologists at the back of our minds, but we don't always get that information from, especially teenagers, right? If they're seeing us in clinic, they're not necessarily going to share that level of, hey, I don't feel comfortable taking a selfie, or like,
Yeah.
I don't like my graduation photo, or I mean, it's actually heartbreaking. Like, these are such important parts of someone's life, and we know acne doesn't end in teenagers. It can progress.
It can progress.
We have a lot of adult female acne, and so it's kind of incredible to see. But what is different, like you mentioned, what do you think about the 80%? Like, do dermatologists bring up technology first? I know we do with scarring. Do we go there a lot with the first treatment of acne, or are we just mostly doing topicals? I mean, the data shows we're mostly doing topicals.
I think mostly topicals, and I think it also depends on the type of practice. You have practices that are primarily medical practices. You have practices that are primarily cosmetics, and then you have practices that are sort of in between. And then you also have this concierge model or direct pay model, right, where those practices tend to be a little bit of medical, but also cosmetics. And so I think it depends on the practice setting, because the average patient that's coming in, typically, especially if they're young, my practice is in San Francisco, for example. I see a lot of young patients, 20-year-olds with acne, maybe not a lot of disposable income, but when they come in, they are expecting to use their insurance to treat their acne. And so those patients are typically, I mean, they do want all the things, they want all the cool things we have, but they kind of expect to have a third party paying for those treatments. And so I think the expectation is there from the patients. They look at us, we're dermatologists, we are the experts on skin, we're the experts on acne, but there's again this disconnect between what they're expecting and what we're able to deliver because of who's covering the visit. So I think that's number one. And then number two, I think for our older patients, let's say 30s, 40s patients, like more adult acne, hormonal acne, those patients, they've already dealt with the teenage acne. They know about retinols, retinoids, tretinoin. They don't really want any of that stuff. They're like, I don't have time to deal with this thing that's going on my face. So I find that those are the patients that are wanting either steroid injections to improve the inflammatory acne. And that's usually where I segue into, hey, sure, I could do that, but we could also introduce technology. So I find that it depends on, one, the age of the patient and how much disposable income they have, and also what their experience is with acne. Or older patients tend to be more knowledgeable about all of the different modalities that we have, and they tend to be a little bit more resistant to the medical treatments. And they just want give me the fast, like most effective stuff. And so it's a very interesting observation. And certainly my practice, I think because I've had those patients that just want like the quick treatments, like give me the most effective. I've now started, when I see my younger patients, I explain, okay, when we start a medication for acne, it takes about 6 weeks to know whether or not this is the right medication for you, the right dosage, the right way of using it. And I'll see back in 6 weeks, and we could always change things up, improvise, etc. But I also say, hey, do you have a function that is coming up like in 6 weeks? Like, do you have something that like you need to get to where it's imperative that your skin is looking clearer sooner? And if that's the case, I have all these other things that we could start, and you could start seeing improvements in about a week. So I do tend to introduce that pretty early on in my practice now, just because I have the patients that want and expect that. So it's something I've had to incorporate in my practice over the past few months.
Yeah. No, I love that overview, because there is this arbitrary like medical versus cash pay, and that's just set by insurance. That's not a medical. I mean, these are all the tools we have.
Right.
And then there are some lasers and things for other conditions where insurance will arbitrarily cover them. So it's not like it's such, and it's crazy to think about, but it's true. There's all these real world, there's health equity pieces, and there's all these other things to it. But when you think about what's available now, but then you're right, you have to kind of navigate this whole system too. And you let us know too, Eric, if there's anything that I know there was some studies I saw with like just even how much money people are spending on just all the stuff at like a Sephora haul and things like that. I mean, it's a whole thing when it comes down to the finances of acne too. Right. Like there's so much.
Oh yeah, skincare investment.
So much to it.
What they're doing in their daily routine, and then a lot of the times it's what they see on TikTok, Instagram. I'm curious to know, what is some of the biggest acne myths or like maybe questions that you're getting that you're like, where is this coming from? Because coming from like a marketing social side, I think it's so important to like debunk some of those.
That's such a good point.
Yeah,
what are the top
patients?
So much. Yeah.
I mean, first of all, I find that I always find that it's really interesting that patients spend all of that money like chasing TikTok trends, right? Like buying all of these topicals. And then when they get to the office, I think they've already spent so much money like doing all the things that the internet tells them to do, that they really just want their insurance to cover the visit. I think that's part of it. But I'd say the biggest trends are something called slugging, right? So like using tretinoin, like covering your face with like castor oil or like Vaseline or all this other stuff. And so that's a big one. Another one is, how like when you start topical retinoids, there's a period where your skin gets a little worse, like purging,
Yeah,
right?
the purging.
So that's another, I think it's another like buzzword on like TikTok. Patients talk about them like, is this going to purge because I can't deal with the purge? I'm like, well, the purge is good. It means
Yeah.
that you're getting rid of that follicular hyperkeratosis. You're actually cleaning out those pores. Purging is good. Like, I can't deal with the purge. Big things are like AHA, like alpha and beta hydroxy acids. Patients using like different combinations at the same time, in addition to like retinoids. And so by the time they come in, their skin is just fried and dry and like highly irritated. And so when I say, hey, but let's get you on tretinoin, they're like, I'm already doing all this and my skin is not happy. I'm like, yeah, it's because you're doing all these other things that are actually not as good as a topical retinoid, but because they're all acidic and all highly irritating, your skin is just not happy. So I find it really interesting that we have all these trends on TikTok and they're supposed to be helping the patients, but they're really not. So I think dermatologists need to be pretty much the voices like up front and center to advise these patients and also help influence those trends.
Yeah, absolutely. That's actually such a good point, because we can't ignore that social media drives so much of our patients' decision making, especially in that teenage subgroup. I mean, there's been patients where I've talked to them about isotretinoin and Accutane for like a long time, and there's a lot of myths about Accutane and isotretinoin, which we have to debunk constantly, in clinic. But I've had patients where they're like not quite comfortable, but then eventually they saw something on like TikTok and they came back, like, now I feel comfortable doing this because I saw, So we just have to understand that that's just part of it. Like, you're gonna have to like navigate that whole system.
Yeah, no, totally.
As well. So, but it's really interesting when you do, because I think, for a while too, for me personally, traditionally, when it came up, acne laser, I equated them to like the light-based devices that were more anti-inflammatory, but not a long-term kind of suppression. So for me, it was kind of like, well, why spend money on that? Versus now we do have technology that actually kind of works like what the mechanism of isotretinoin, which is like kill off the sebaceous gland, which then that's the only way you can really get this like a long-term cure. Not even the suppression of the sebaceous gland or like sebostatic effects, which you can get with low-dose Accutane and sometimes with some topicals, but even that's hard to do because that's going to bounce right back.
Right.
But it's that sebocyte apoptosis, like zapping the sebaceous gland. And we had a talk recently where we talked about it takes super high doses of Accutane you can suppress the sebaceous gland with the less dosages, but you need really high doses of Accutane to actually start killing off so these novel therapies like the 1726 is super novel for like literally being able to zap it. And I thought it was really interesting. You mentioned you actually do really high dose Accutane, because most dermatologists will go for 120 to 150 mgs per kg and then just kind of monitor the skin. But monitoring the skin, it could be sebostatic, where things are kind of suppressed for a month or two, and you're like, we're pretty good. But unless I guess you're doing a punch biopsy, you're not, sure, where you are with your sebaceous glands, if they're just going to like rebound right back up or not. But you kind of go the higher.
I go higher. I mean, maybe 6 years ago, I remember when I was in training, the dogma was about 100 a cumulative dose of about 150 mg per kg. But then the rates of recurrent acne was pretty high, about 10% roughly. And I remember reading a few studies that showed that getting to a higher cumulative dose actually resulted in a much lower rate of recurrent acne. So patients needing a second or a third course of Accutane. And so I actually shoot for 220 mgs per kg. It takes about 9 months to get there. And I find, again, much lower rates. Now, interestingly, when I do have patients who come to me with bad acne and they go, hey, I've had Accutane before, and this is like my second or my third course, it's usually patients who've had the lower cumulative dose. So I think that there is some data to that. And also in my own like real life experience as a practicing physician, I do see that. So I tend to go for the high, like the patients that are needing Accutane in my practice, like they need Accutane. And so I hit them hard. I start slow. I usually start with half. So the target dose is about 1 mg per kg. The first month I start with half of that just to make sure they're tolerating it. But once that first month is good, I hit them hard.
Yeah, no, and I love that about, and you're most surgeons, of course, you're like, let's get in there, treat the thing, and that's a good thing. When someone's coming into your office, they don't want to mess around.
Right.
But it's true, it does really take that length of time to start getting there. And then the first Avaclear studies were with three treatments, so one a month, and then you see like this clearance up to about a year, and even post a year. And then recently there were some new studies, kind of real world, where you can kind of, because that's kind of what we do. There's art to it with like an isotretinoin, and there were some studies of like, do you do a fourth treatment with Avaclear? And I don't know if there's a consensus or I think it's early data, right, from the real world data of co-treating with other therapies and possibly doing more than the three. So it's kind of interesting seeing how they're not exactly the same thing, but there are only two modalities of killing off the sebaceous gland, to put it kind of
Right.
in a simple term. So it's interesting as it pans out to get an idea of how many treatments equals these dosages.
Right.
And now we know it takes a lot to kill off a sebaceous gland and
Right.
keep it away. Like we know that from our isotretinoin
Right.
data. So it'll be kind of interesting to see, like in the end, like how many percentage of patients that will probably need a fourth, or possibly, but it's amazing that we have these options now, because we haven't had anything in the past that's been able to do
Right.
what
Or
isotretinoin
even just
can do.
like a maintenance treatment, right? So like maybe even a fourth, not even a fourth one, but like after the three, like do you need like one a year or something? I don't know. I don't know. Or is there a role for other modalities? Interestingly, I remember back in, I want to say maybe the 2000s, and I'll talk about this tomorrow, but like photodynamic therapy, things like IPL or broadband light, were used to manage not just like the number of acne lesions, so like actively killing off the P. acne species, right, that causes the bacteria that causes acne, but also targeting the inflammatory aspect. So like having like a yellow or a red light targeting the vascular component of acne. So you're improving the redness like pretty quickly. And then because you're doing that, the likelihood of having like depressed scars is actually lower. So I remember reading these studies, like I'm gonna say like the 2000s. And I remember reading that if you did those usually pretty regular, like about every week or every 2 weeks, it showed there was a rapid improvements in the number of acne lesions, but also the inflammatory, the post-inflammatory erythema. And those results lasted usually about like between 6 to 9 months, but then they always needed maintenance therapy, right? And so we're coming from that technology to something that has the potential to have staying power, right? Where the patient is clear for like months and maybe needs maintenance. So it's certainly it's exciting having this additional tool in our toolbox, right, of things we can offer acne patients. But it's good. It's good that we have more tools.
No, absolutely. And I think I love new things coming out, because it kind of makes us even question our older modalities. Like, because there hasn't really, like with sebocyte biology, there hasn't been a whole lot of movement in that space. And we know you're not going to, like you said, with the light-based IPLs, it's going to come back. The acne is going to come back. Your only cure is to decrease sebaceous glands. And to me, it makes the most sense to do it locally where you have too much sebaceous gland activity. Like, why put your whole body through these super high dosages? I love you shared some histology data that I think was presented. Was it at ASLAMS? No, ASDS or ASLAMS recently. And it was like, I'm trying to find the actual slides. But basically, what it was is, I think there was in facelift patients. They were just they were going to remove some skin anyways. What they did is zap with higher and higher amounts of the 1726 nanometer, and just to kind of see how much you can push this technology. And it's actually, that's really cool to see, is like, well, maybe as the technology, as we're learning more and more about it, you just can, like, what needed previously 220, let's say, mg per kg of isotretinoin, can you do that with this level of energy? So I think, to me, that's really exciting about just learning these things about sebaceous biology or sebocyte biology.
Absolutely. And I think we're just now, right, it's the tip of the iceberg, especially with like the 1726 being so novel. It's only been in the market for 3 years. And it's like, when I look at, and I was actually thinking about this on the drive up, because I was thinking about, how early, like, right, there's new aesthetic brands, I think, that pop up, or treat, like, same wavelength, but it's maybe like a different treatment brand, that comes across, the pipeline every year. But I think with this being so new, we're just now finding out like so much more. And we are getting the early 18-month data. So we have 18-month data that we presented at ASLMS 2 in the histology, which was amazing to really revisit that. And since it's been 3 years, we know the range, the fluents in which we should really be treating and what's been working in the real world. It has been really interesting to see the selectivity, the proof, the validation behind the wavelength and what we're doing in this spacious gland destruction.
And there's just so much that's going to come out. So excited. But we can't end without, you mentioned post-inflammatory erythema.
Right.
And of course, there's a whole lot of things we have to do for acne scarring. There's the ablative lasers and all this. But I think if anything else, we just can't leave without talking about post-inflammatory erythema, because we know in the patient acne journey, until that redness is gone, their journey is not done. And this is like the classic case of like your MA comes out and says, your Accutane patient's in room 4 and they're saying it's not getting better. You walk in, there's 0 acne spots.
Right.
And they're like, no, I still have acne.
Right.
Until that redness is there, they have acne.
Yeah.
And so we got to touch on that. And also you ask like what myths, and there's a myth of, oh, you can't treat that redness while on Accutane, isotretinoin. So I don't know if you have like any comments of just like finishing that journey, like don't leave the patient halfway.
Yeah, no, absolutely. So for my medical patients, right when, as soon as the lesion count has gone to 0 and a lot of those patients are actually pretty happy. They're like so happy. And I'm like, okay, your acne is gone. Now there's redness. And see, this is what they say. They usually say, well, my acne is better, but I have these scars and I want you to talk to you about the scars. And I go, the good thing is these are actually not like scars in the way you think of it. I think of scarring as textural abnormalities, like either hypertrophic scars or depressed scars. But if there's just color, whether it's post-inflammatory hyperpigmentation or post-inflammatory erythema, I go, the good news is that we can get these better and get your skin looking better. So I find that patients really hold on to that. They're already so happy that their lesion count is 0 and they're like, okay, this dermatologist has already made my acne better. I trust her to do X, Y, and Z. And that's where, even for the medical patients, that's where you can sort of, again, as a practice owner, you can sort of provide ancillary services. So laser treatments for PIE, or I compound hydroquinone in the office. And so for my patients of color with just hyperpigmentation, then I compound, hydroquinone-based therapies to improve that. So that is part of the acne journey in my practice. It's not just getting the lesion count to 0. It's also doing all these other things that take away that stigma, right, of having acne. And their patients are super pleased with that. Now, beyond that, so when we improve that, then you start seeing the textural abnormalities, the ice pick scars for patients who've been on Accutane, or the rolling scars. And that's where we get, we bring out the big guns to treat. So they're even further treatment. So pretty aggressive. I tend to use more ablative laser resurfacing modalities. I do like full face subcision under tumescent anesthesia.
You presented this last year, and I think everyone, and there was a dermatologist in the audience, and we're just like, what is happening? It's amazing. And the results were amazing.
Results are so good. It's usually a one-time treatment. I find that better. I used to just do like fractional ablative resurfacing, and I find that you just don't get the same results when you're not like treating it like all at the same time using different modalities. So those are for like the patients with the worst scarring. I find that this is another thing that I do find that if we start treating the erythema early enough, you could actually prevent some of the scarring. So for a lot of my younger patients, so I think more teenagers with like wealthier parents, etc., especially patients who don't want to use systemic therapies, I go, okay, if we can't use doxycycline or spironolactone to get this better quickly, why don't we start a vascular laser treatment? We started soon. We're using the topicals, but we can start treating the erythema before it leads to scarring. So doing that early can prevent, like the deep scars that need the combination, like big guns treatment. So I think that absolutely technology in the acne journey, it's very important. It's number one, but it's also important to introduce it early for a lot of the patients. And I think it just helps the patients improve much faster and also prevent some of the harder sequelae, like the deeper scars.
No, I love that because you're debunking 2 myths there. One is a lot of people say like, oh, you can't treat erythema with like vascular lasers while on Accutane. You absolutely can, and you should. The other is you can't do lasers while you have active acne, which is kind of true sometimes. I mean, except for the apocrine, but you can do the vascular, and there is a point to it, because if you're not, if you're going to get on Accutane, sure, let's start that process first. But get rid of potential scarring any way possible. Who cares what point we're at? We want to minimize scarring because that's what's going to last long term for this teenager that's going to have to deal with it for the rest of their life. So
I think it depends on the type of laser, absolutely, right? So like for Accutane, the issue is that there's delayed wound healing. So you want to avoid the ablative treatment while they're on Accutane, but absolutely
make that clear.
Exactly.
Yes.
Everything else, vascular laser, even like bulk heating, right? Because bulk heating, you're actually like stimulating collagen, and that actually helps prevent some of the scarring or helps treat some of the early scars. So I'll talk about that tomorrow too. Things like skin tight. I mean, you don't have to like have all the expensive lasers, just like whatever you have in your practice.
For sure. And it's a good thing you bring up with your bulk heating, actually, because I do see with the AviClear patients, actually, like I don't tell them this is for scarring because like we don't want to give problems, but is that improvement with the scarring. It's probably just a bulk heating. So you're kind of doing both. And of course the Cutera lasers, I think that's, you guys live in that world where you're like, how do we treat these things? All, put the RFM with the laser, and you're living in the world with the engineers of coming up with these devices of like hitting it hard all at once, having these modalities together. So
yeah, absolutely. And it worked, with AviClear introduced into the portfolio. It was such a natural next step because synergistically, Cutera devices were really developed to specialize in specific skin conditions. And with the XLV Plus, our 532 laser, like that has been such like a gold standard in being able to treat some of the toughest, vascular concerns. And then you have Zia, which has our 1064 laser Genesis, which is great. A lot of people use that in between AviClear treatments because they are starting to see in the real world, get that patient journey in there to, sooner, so that the outcome, they're just so much happier. And then the RF microneedling and CO2 or 1540 combination. So we were able to develop protocols where you can stack RFMN and laser treatments at the same time. And that's been a really winning combination, especially within the patient journey. After the acne is treated, they're X amount of months, starting to see improvement. Then it's an introduction of, okay, do we take a vascular route here? Do we start, concentrating on the scarring? So it's been really, really cool to see just how much, collaboration and creativity the dermatology community has really been able to contribute using all of these different light-based modalities, especially in the acne patient journey along with AviClear.
Yeah, that's fantastic. Well, thank you both so much, because we're talking like two different worlds, but of the Mohs surgery, going in with the tumescent, subcision, and then from the technology world, working with the engineers to layer the technology and what is safe to do one on top of each other. But I think the theme there is we're taking acne a lot more seriously. And we're just like, okay, it's not one size fit all, but there's all these modalities. We're not going to leave you halfway there with just the redness, the pigmentation, and all of that. And we know it's a condition that really, really affects people, and it can change the trajectory of people's lives.
Absolutely.
Scarring or how the experiences they had as teenagers or into adulthood. So it's Acne Awareness Month. So we had to take a long time to go through that whole journey. And I can't imagine doing it with any two better, co-hosts. So thank you both so much for joining, and all your pearls and all the work you do every day for treating our dermatology patients and our acne patients.
Thanks for having us here. This was great.
Thank you so much.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.